Good afternoon to everyone.
Good afternoon.
Good afternoon, miss.
Good afternoon.
Thank you for Professor Zurabebova. I'm very happy to be here today and share this session.
Yes, Maria Grazie. I would like to represent you for our participant, for our young scientists. Dear scientists, young scientists, dear colleagues, let me introduce moderator of your section, Professor from L'Aquila University, my closely friend, Maria Grazia Palmerini. Today, she will moderate you and evaluate your topics and give a prize for best scientific research. I think it's a very good possibility to show for all world your results, your skills, your strong work during this year, very difficult year online. Every time is online. We tired, a little bit tired, I think. And today, a very good day. And some participant will join us here, or some maybe if we'll have problem with the Zoom, will search in the YouTube, because here is translated in YouTube too, parallel. Okay.
It's an honor for me to chair this session. I'm very happy that Professor Zurabebova, as a president of this Congress, is giving to you the possibility to show us your skillful. I'm sure that you really are strong students. You work hard. So today, I'm very, very convinced that you will show your best results. So it's a good opportunity that Professor Zurabebova is giving to you. So I think we can start this session. So I'm happy and glad to introduce the first speaker, Guljamal.
Good afternoon, ladies and gentlemen. I really appreciate that welcome introduction and deeply delighted to be here as this long-awaited event. This is Sigidova Guljamal. Let me demonstrate my PPT. 1 minute. So can you see my title of presentation?
Yes, yes, perfectly.
Okay. It's a great pleasure to meet and start our section.
Okay.
So today we talk about oncomarkers. Our topic is CEA, correlation with mutation used for the disease course monitoring in patients with colorectal carcinoma. Colorectal cancer is a dreadful health problem everywhere. Around 608,000 worldwide deaths are related to colorectal cancer. More than 300 deaths of colorectal cancer are registered annually in Kazakhstan, and 1,500 patients die. It means every day 4 people die from colorectal cancer. Also, local researchers had found almost 3-fold increase in rectal cancer incidence in tens in October. So our aim is CEA correlation with tumor mutation used for disease course monitoring in patients with colorectal carcinoma. Our objective is first to determine the baseline level of CEA biomarker in patients with newly diagnosed colorectal cancer, and compare level of marker before treatment and after treatment. It means after chemotherapy, surgery, and radiotherapy, after 3 months and after 6 months. So we plot 3 times before treatment and after treatment. Second, determine the levels of CEA biomarkers in patients with clinical condition, metastasis, clinical recovery or relapses, and also tumor location. Using the methods of statistical analysis to identify the most characteristic values of markers, the value of their proportions with clinical established clinical state. So our method. Patients with newly diagnosed colorectal cancer of any stage are enrolled without randomization. Based on information of cancer registry, the average incidence was calculated and it was 9.3, and the sample size of 122 people was determined. We used computer tomography and the MRI and the studies to confirm colorectal cancer. The 5mm venous blood sample was collected using aseptic technique. The serum was separated by centrifugation and stored at minus 80 Celsius until analyzed. The serum was analyzed for TEA. So you can see here our result of the blood test. You see here patients' district number and the age there, the sex, and the weight, height, and the diagnosis of them, and the clinical state. And the last graph shows the information about the TEA level. It is a different level. So also, there is information about TEA. We, by the end of the calendar year, a total of 116 people were examined. Estimated sample was 122, so it's almost 100%. Of this, only completed second round of the valley. It's 43%. The planned third round in 6 and 9 months after passing the first analysis, it's not performed because we have only 2 people and that's not enough. Average age of the sample, it was 60 for female and the male. So you can see here results of TE by the stage and by the location. So there is no significant relationship between the levels of markers and the staging of the process, how we see here. So look at numbers by the graph. No increase in the values of markers dependent on staging, which is associated with the uneventness of the sample. A weak correlation of indicators of TEA markers in the staging process was revealed. So there you can see also TEA markers by their ascending column, descending column, rectus medium, and the rectum. So you can see here results. This circumstance could be associated with the defect of disturbance of patients by the outside. We have patients with stage 1, only 2 patients, 88 participants with stage 2, and only 12 participants with stage 3. There is also a great variability in the disturbance of indicators. Indicators for stage 3 are knocked out of 0, how you see before. Correlation of marker levels with association of clinical site of patients upon administration for TE experiments is moderate. This data generally allow the TE marker to be used in clinical practice to assess the patient's condition over time, improvement, deterioration, relapse, and remission. Data from the second round of observation, we have 50 patients there. A significant moderate correlation of the TE marker values with the assessment of clinical state was revealed 0.29. The correlation of the TE marker with the staging of the process was obtained higher than the initial assessment. It's moderate. No correlation was found with the localization of the process for CEH. Our conclusion is the result of the study can be considered moderately valid. The main reasons for the insufficient validity are lack of observation in dynamics, which is associated with time constraints, as well as the high heterogeneity of the sample in the disturbance of main features. It can be staging of the quality process, age of the patients. Also, no correlation was found between the marker values and the gender, age, ethnicity, and the colorectal cancer localization. Taking into account the result obtained of the CA marker correlation with the clinical state rate, in general, it can be used for dynamic monitoring patients' colorectal cancer in clinic, taking into account insufficiently high correlation with the staging of the process. So, thank you for listening.
Dr. Maria Gracia, your microphone is off. Could you please switch on? Dr. Maria Gracia, can you hear me? Sorry, your microphone is on.
Sorry. I apologize. Thank you, Guljaman. I was asking, these results are interesting because you didn't find a strong correlation, but did you also try some other markers for colorectal cancer like CA19-9 or only this one?
We use TA19 and 9. It shows lower results than T. So for this scientific project, we want to show results on low of CEA marker.
Okay, thank you very much.
Thank you.
Okay, we can move to the second speaker. So I invite Abdul Razak Imran Khan from Dubai, United Arab Emirates.
Hello, Miss.
Good morning. And Imran, we speak about a novel biomarker distinguished the benign-looking ectopic follicular thyroid tissue from malignant found in the cervical lymph node of thyroid tumors. Please, you can share your presentation.
Yes, sir, Miss.
Okay,
Hello, ladies and
perfect.
gentlemen. My name
Yes.
is Abdul Razak Imran Khan, and my topic is a novel biomarker distinguishing the benign-looking ectopic follicular thyroid tissue from malignant, which is present in the cervical lymph node of thyroid tumors. And I have carried out this research in collaboration with Nagasaki University, Japan. So, as we all know, tumors consist of two types: a benign form and a malignant form. Under thyroid tumors, in the benign form, we have the follicular thyroid adenoma as well as other forms, but currently we have taken this form because it's one of the most prevalent form. And under malignant, we have different types of carcinomas, but in this case, we have chosen the well-differentiated thyroid carcinoma, which in turn consists of the papillary thyroid carcinoma and the follicular thyroid carcinoma. So as we know, malignant tumors may give metastasis, and most often they give metastasis to the regional lymph nodes. If in the thyroid tumors, benign-looking ectopic thyroid tissue in cervical lymph nodes are present, it would be referred to as an ectopic thyroid tissue by some pathologists. But it is under controversy whether they are heterotropia or malignancies. Although some pathologists may suggest that the thyroid tissue in the lymph nodes are automatically cancerous, regardless of their morphology. However, the histopathological criteria of inclusion as an ectopic thyroid tissue is accepted if they do not show the histologically nucleatypia, or like as we see over here in this picture, or features of papillary thyroid carcinoma such as nuclear clearance, grooving, and pseudo-inclusion bodies, as well as samoma bodies, microcalcification, and desmoplastic stroma changes. Also, the invasion to the stroma or undercapsule in lymph nodes and no extension into the nodal parenchyma are also taken into account when detecting for ectopic thyroid tissue. So let me briefly explain about the embryological and anatomical aspect of the thyroid gland. The thyroglossal duct is an embryological anatomical structure forming an open connection between the initial site of area of development of the thyroid gland and its final position. It is located exactly midline between the anterior two-third and the posterior one-third of the tongue. And the thyroglossal duct remnants are the most common midline congenital cervical anomalies, but as I described in the previous slide, they occur in the lower neck, and the remnants usually lie in close proximity to the hyoid bone. And ATT has also been reported in patients without thyroid cancer. But as we can see, nevertheless, the fact that benign thyroid tissue has been reported in patients without histological evidence of thyroid cancer and carcinoma, and up to now, evaluation of ectopic thyroid tissue in the neck is considered as controversial and disputed. So in fact, in the recent published papers, it was noted that the prevalence of ectopic thyroid tissue in the autopsy studies varied from 4.7% to 10%. And to the best of our knowledge, a comprehensive study by Diana et al. Shows a molecular analysis with histological review of ectopic thyroid tissue, which concluded the lack of common carcinoma-associated mutations such as BRAF, HBME1, and galectin-3 in the immunohistochemistry, which supports the benign nature of this entity. And also these markers are accurate and helpful when not enough tissue is available for molecular studies, but the malignant but further concern of malignant transformation of ectopic thyroid tissue is usually taken into account, since the above mentioned markers are only associated with some subtypes of PTC, and the prevalence is different in various populations, which sometimes they may be drastic. For example, in case of the Americans, the percentage of BRAF can range from 30 to 60%, whereas in the Kazakhstan or Japanese population, it varies from 40 to 60%. So my question, so every pathologist faces the question less or more during their histological examination, since TNM grading and staging influences the prognosis of the patient. So the question is how to interpret collections of normal-looking colloid containing thyroid follicles in lymph nodes. So to answer this question, we use the immunofluorescence staining with 53pp1 that is known as a marker of genomic instability. The genomic instability is a hallmark of cancer, which allows cancer initiation, proliferation, and progression through the accumulation of driver mutations. Genotoxic agents such as radiation usually induce incidental DNA damage and activate the DNA damage response pathways to maintain the genomic integrity of the cell. A failure of this DNA damage response pathway can result in genomic instability, which generally is considered a central to any carcinogenic process, and it has been documented by immunofluorescence studies that 53pp1 might serve as a valuable marker of genomic instability during carcinogenesis. So the aim of my study is to evaluate 53pp1 expression in lymph node with benign looking ectopic thyroid tissue and metastasis. So the material in this case study was consisted of 18 cases of thyroid tumor, which included 17 of papillary thyroid carcinoma with metastasis and ETT in lymph nodes, and 1 follicular adenoma with ectopic thyroid tissue in lymph nodes. And the definition of ectopic thyroid tissue can be given as thyroid follicular cells without atypia and nuclear features of papillary carcinoma in the cervical lymph nodes. So my contribution to this present study was evaluation and counting of expression of 53pp1 in cell nuclei. So 53pp1 can be classified into the following 4 types, which consists of the stable type, as you can see over here in the leftmost, which shows faint and diffuse nuclear staining. The second type is a low DNA damage response type, which shows 1 or 2 discrete nuclear foci, and the high DDR type, which shows 3 or more discrete nuclear foci or focus as more than 1 micromillimeter. And the last one is the abnormal type, which demonstrates an intense and heterogeneous nuclear staining of several small foci. So at this point, let me explain about the interpretation of expression of 53pp1. Usually, normal cells have faint and diffuse nuclear staining, and benign tumor of thyroid, such as in follicular adenoma, usually shows a faint, 1 or 2 only nuclear foci, and then furthermore, the malignant thyroid tumors usually exhibit an intense and heterogeneous nuclear staining of 53pp1 nuclear staining, and focus as more than 1 micromillimeter, as in this case. Also, high-grade thyroid cancers additionally demonstrate intense heterogeneous nuclear staining that is equivalent to the abnormal type of 53pp1 expression. So finally, our results of staining with 53pp1 in thyroid tissue with PTC showed intense and heterogeneous nuclear staining, and a foci of more than 3 foci, or foci size more than 1 micromillimeter, as in the case of papillary thyroid carcinoma. And in case of benign thyroid tumor such as follicular adenoma, we saw a faint and diffuse nuclear staining and 1 nuclear foci that was not easily diffused spread in tumor. So staining with 53pp1 in lymph nodes with histologically malignant follicular cells, such as in case of papillary thyroid carcinoma, shows 3 or more nuclear foci with heterogeneous nuclear staining, and all benign looking ectopic thyroid tissue showed faint and diffuse nuclear staining with 1 nuclear foci that was again not diffusely spread in follicular cells. So to highlight the follicular epithelial cells in the lymph nodes, we use the AE1, AE3 marker, and finally double staining was performed in all lymph nodes. In the high magnification, we can see expression of 53pp1 in lymph nodes showing 3 or more nuclear foci with heterogeneous nuclear staining and metastasis in the case of papillary thyroid carcinoma, whereas all benign looking ectopic thyroid tissue shows faint and diffuse nuclear staining with 1 nuclear foci that was again not diffusely spread in follicular cells. So in summary, a high or abnormal expression of 53pp1 was found exclusively in thyroid follicular cells with atypia and PTC nuclear feature in thyroid tissue and lymph node tissue, while stable expression of 53pp1 was observed in follicular adenoma and the lymph node with benign looking ectopic thyroid follicular cells. So in conclusion, 53pp1 immunofluorescence analysis is a useful marker for differentiation of ectopic thyroid tissue for metastasis. Thank you.
Thank you very much for these beautiful pictures. I really like it. Did you also quantify the altered expression of this marker?
Yes, we have done, but because of the data and all, we usually just added these main points of the patient, just mark the pictures, the histological pictures of the expression of the.
So you also made the Western blotting, some other technique to make a quantification.
Yes, but no, but for some cases, usually for the beginning, but rest of them, we usually used just the immunofluorescence analysis in this case only.
Okay, thank you very much.
Yeah.
Okay, we can move to the third speaker. That is Valery Ignatiev, and the topic is renal artery variability according to computer tomography.
Hello. Just 1 minute.
Yes, please. Okay, perfect.
Dear colleagues, allow me to present the theme of the scientific work, renal artery variability according to computed tomography. Due to clinical significance of issues of renal vascular anatomy, they are constantly attracting their researchers' attention. Moreover, the special attention is paid to their extra organ part, as it is important for surgical practice and modern methods of instrumental diagnostics. The analysis of new references suggests that the coverage of both individual and renal blood supply variability is not always ordinary, which determines the relevance of the research. The aim is to search and study the variability of renal arteries. So the material of the retrospective study was 500 CT scans with contrasted renal arteries in patients 27-82 years old, male and female, who were examined in the Department of Radiation Diagnostic of the Aktobe Medical Center for 2017 to 2019 by using the apparatus General Electric 2013 Optima 660. The variants of discharge and topographic and anatomical features of the renal arteries were studied. Here you can see the apparatus. The average age of men was 51 and the average age of women was 52 years. So results. Scalotopically, left renal artery origin at the second lumbal vertebra level was more often found in men by 40.2%, and right renal artery origin at the first vertebral level was found more often in women by 8.6%. Here you can see this one. The anterolateral origin of the aorta of the right renal artery in men was 2 times often met. On the right, the length of the renal artery in men was more than 0.7, and on the left more than 0.4. Excuse me. The diameter of the right renal artery in men was more than 0.50, and the left renal artery was more than 0.1. Yeah. And the ascending course of the right renal arteries was in women was more common by 6.8, and the rectilinear form of renal artery in men on the left was detected more often by 21.0%. And about the arched up form, it was revealed 2.4 times more in men, and with the arched shape up, it was revealed of the left, it was revealed 1.8 times more often. So analyzing the quantitative variability in the blood supply of kidney, we detected the presence of up to 3 and 4 arteries. And about these results, please pay your attention at the figure number 3. Here, 3 branches ran to the left kidney. 2 upper vessels arise closely, and the third one separately. The following figure demonstrates 4 arteries on the right, 2 of which was raised from abdominal part of aorta, and another one from mesenteric artery, and the fourth branch was arising from the right common iliac artery here. By gender, the variability in men was 58%, and the variability in women was 45%. So the results of the research confirmed the variety of options in renal arteries, which were proved in 73 cases. Knowledge and accurate identification of the renal arteries structure will assist to avoid vessel damage in kidney surgery. The presence of deviations from the classical anatomy of renal arteries prompts researchers to search for methods to improve the results of surgical treatment of patients by reducing the risk of possible complications. The data of variability of renal arteries confirm the multi-vector variability because more and more forms are still being discovered. Thank you.
Thank you very much, Valerie. Very interesting results. And it's very important for a surgeon to know this variability. So I thank you for your presentation. Okay, we can go on with the last Young Scientist contest. So I invite Gizem Han Baybars from İzmir in Turkey.
Hello, ma'am.
Good afternoon.
Good afternoon.
And she will present to us the third promoter maturation as an early genetic event activating genomic instability in thyroid tumorigenesis. Please.
Ma'am, can you see my screen now?
Yes, we can, perfectly.
Okay, miss. This current project I carry out in collaboration with El Farabi Kazakh National University and Nagasaki University in Japan. So let me introduce my talk with the classification of thyroid tumor by World Health Organization. As we know, all neoplasm includes benign and malignant compartments. The thyroid benign neoplasm is presented by follicular thyroid adenoma and the recently introduced the borderline precursor tumors, which are well-differentiated tumor of uncertain malignant potential and follicular tumor of uncertain malignant potential. The malignant neoplasm includes the well-differentiated thyroid tumor that are presented by papillary carcinoma and follicular thyroid carcinoma. Here, as you can see, the follicular adenoma as well as follicular carcinoma are both encapsulated and histologically similar. However, follicular adenoma is a non-invasive neoplasm that have good prognosis, no metastasis, and no recurrence. And next benign tumor is uncertain malignant potential according to 2017 WHO criteria that exhibit an suspicious invasion to capsule and or ejection blood vessels, in which clear-cut invasion cannot be ruled out of with absolute certainty. The diagnosis of follicular thyroid carcinoma is based on the identification of demonstrable malignant behavior, namely capsular and or vascular invasion. This invasive growth and metastasis often leads to death from disease. According to WHO classification, well-differentiated tumor AMP shows a small amount of histological features of papillary thyroid carcinoma, such as nuclear clearance, growing, and pseudo-conclusion body, and not clear invasion to capsule. On the other hand, we cannot find any histological features of papillary thyroid carcinoma in follicular thyroid in a certain malignant potential, but suspicious area of invasion to capsule also present. Here, the third is telomerase reverse transcriptase, which is responsible for the extension of telomerase at the end of DNA strain. Two common mutations in TERT promoter C228T and C250T have been associated with many types of human cancer, including thyroid. It's present in 70% of follicular carcinoma and 11% of papillary thyroid carcinoma, and was described with association with overall poor prognosis and death from disease. Also, according to recent three publications, TERT promoter mutation may occur in benign thyroid follicular tumors, such as follicular adenoma and uncertain malignant potential cases. And some of them showed recurrence and death from disease. Thus, still remains unclear whether the TERT promoter mutation that is present in primary tumors diagnosed as follicular adenoma and uncertain malignant potential have the potency to lead to progression of thyroid tumorigenesis. My question is the study, does the TERT promoter mutation that present in primary tumor diagnosed as follicular adenoma and uncertain malignant potential have potency to lead the progression of thyroid tumorigenesis? To answer this question, we used immunofluorescence analysis for 53 binding protein 1 expression. 53BP1 was documented as a valuable molecular marker of genomic instability during carcinogenesis. As we all aware, genomic instability is a hallmark of cancer, allowing for cancer initiation, proliferation, and progression through the accumulation of driver mutation. In our result, the TERT promoter mutation was found positive in 3 out of 26 cases of follicular adenoma, 3 out of 26 cases of uncertain malignant potential, and 3 out of 20 cases of follicular carcinoma in minimally invasive type. In the method part, we use DNA extraction was performed from formalin-fixed paraffin and beaded blocks. Quantity of DNA checked by nanodrop spectrophotometer. For analysis of TERT promoter mutation was performed droplet PCR, and immunofluorescence for 53BP1 expression was subjected. In this part, my contribution to present study was interpretation of expression 53BP1. As showing on the slide, I used to estimate the level of genomic instability by next 4 type of classification of expression. In the stable type with faint and diffuse nuclear staining. In the second type, the low DNA damage response type shows a 2 discrete nuclear foci, 1 or 2, it depends. In high DNA damage response type with 3 or more discrete nuclear foci, and the last one is abnormal type, demonstrate intense heterogeneous nuclear staining or several small foci. Here there is no statistical difference was found in age and size of tumor. Female is, also female is predominant. Detailed information of my count of 53BP1 expression shown on the present table. Low and high abnormal 53BP1 expression have been counted in average 1050 cells per case. Comparison of high and abnormal expression of 53BP1 between thyroid tumor group with TERT promoter mutation showed a statistical significant difference between follicular adenoma and uncertain malignant potential is P equals 0.021. Between uncertain malignant potential and follicular carcinoma, P value equal 0.032. And finally, between follicular adenoma and follicular carcinoma is P equal 0.001. My obtained results shows increasing tendency of high abnormal expression of 53BP1 in thyroid tumor progression. In summary of my work, I showed TERT promoter mutation was found in 3 out of 26 in follicular adenoma, 3 out of 26 in uncertain malignant potential cases, and 3 out of 20 in follicular carcinoma cases in the minimally invasive one. And high abnormal type of 53BP1 expression increased in next order. Follicular carcinoma more than uncertain malignant potential more than follicular adenoma in the TERT promoter mutation cases. In the conclusion, a thyroid tumor harboring TERT promoter mutation showed progression of genomic instability during thyroid tumorigenesis. Thus, I suggest that benign thyroid tumor with third promoter mutation could show a malignant potency. So thank you for your kind attention.
Thank you very much for this interesting presentation. Did you also study some other promoter, since the percentage of third mutation are not so high?
Ma'am, we didn't study it about other mutation, but as you know, those are found third promoter mutation in a benign tumor is a very rare thing, and
Okay.
we try to find more detailedly, and we will continue, of course.
Thank you very much.
You're welcome.
Okay, so I think we finished the this first session, and now we can move to the student poster session. So I invite Serik Saminov from Aktobe in Kazakhstan that will speak about structural changes and architectonics of brain vessels in practically healthy phases of young age. Serik is here. I think I cannot
no.
see Serik, right?
I think no.
Okay. Okay, so since in the chat there is an interesting question from Dania, she's asking to know the personal contribution of participants in their scientific research. So I invite all the speakers to switch on the webcam and the microphone, because now it's the final moment. We listen all of your presentation, very interesting all. So now I invite you all, following the same order of the presentation. We can start from Gujamal and then we can go on. And I would like to know from each of you the personal contribution. So what actually you did in the study that you presented. Please, Gujamal.
I'm sorry, can you continue, please?
Yes, yes. Not yet the webcam, but we can listen you. Okay. Can you tell us what you did in the study that you presented? What's your involvement?
What I need to do my scientific research? Am I right?
Sorry, I didn't hear from you.
What I need to do my scientific research? I don't understand the question. Can you repeat, please?
Yes, I would like to know what was your personal involvement in the results that you presented? Your personal contribution, what you did?
Firstly, we all collect information about our patients of colorectal with colorectal cancer in Aktobe and in Kazakhstan. And it establishes that we have a lot of patients with this disease, and we calculated only in average 120 patients there. And also after that, we take blood from all of these patients and different all of them with this. We have patients with stage 1, 2, and stage 3. And after that, we take blood of the patients and separated all blood by centrifugation and stored it -80 Celsius until analyze it and analyze them for the CEA. After that, we analyzed all of them and collected all information and tried to compare the CEA levels by patients with the stage, and also encode by tumor location. How you can see before, by location, there is no any correlation. Also, we compare the results by the age or ethnicity and their sex. There is also no correlation there. So we did all researches together.
Okay, and Professor Zurabekova is asking to all of you, so I will start from you, what kind of statistical method you used?
We use Spearman's
Correlation.
correlation. Yeah.
Okay, thank you very much, Gulshrama. Okay, now I invite Abdullah.
Yes, miss. May I share my screen if it's fine?
Sure.
Miss, in this research, we were given cells of the patients, the biopsy specimens from the patients, and they were embedded in paraffin. Once they're embedded in paraffin, we exposed them to immunofluorescence, and then after that, we observed them through immunofluorescence microscope, and we counted the number of nuclear foci that was seen under the microscope. Usually, we divided them into four types. The first one was the stable type, which was the stable type or the normal type, and the second type was the low DDI type, which we contributed them to the which consisted of either one nuclear foci or two nuclear foci, and they were considered as benign nature or sometimes normal, because most of the cells usually they have one or two nuclear strand breaks because of normal environmental consequences. But the third case was the high DDI type or the high DNA damage response pathway, which showed more than 3 nuclear foci or nuclear foci which was larger than 1 micrometer. And we classified this information under the malignant form of the thyroid tumors. And the last one we gave was the abnormal type, which was a high or intense heterogeneous nuclear staining, which represented the most abnormal type or the malignant form, which was usually the last stage of the thyroid cancers. And as for the second question, we used no such statistical methods because our data usually was just comparing histological features of the different forms of them.
Okay, I have another question. Since you told at the beginner that this is a study in collaboration with Nagasaki University, right?
Yes.
Immunofluorescence was done in Al-Farabi University?
No, it was done in Nagasaki University.
So your involvement, your personal involvement was
just to count the cells, each individual cell.
Okay, okay, thank you very much. So now we can go through Valerie.
About contribution, my contribution to the work was a description of making description for all these 550 scans, okay. and making all the tables from this, and so it was a description of features, okay. And features like the level of a region, the diameter. And,
so also the measurements,
yeah,
length, diameter.
The main is to search for the unique variants.
Okay. And what kind of statistic methods did you use?
Statistic methods, like general mathematics,
like you made a median, standard error, or standard deviation.
Yeah, for the especially for the length and diameter, we make this one.
Okay, thank you very much. Okay, Gisem.
Yes, ma'am. My contribution to this study is the counting the cell during the the foci, and we just use some statistical methods for this, like p-value and all. Because of the pandemic, we cannot be part of a laboratory part, and we can just join in the statistical part, unfortunately.
Okay, no problem. I understand. Thank you very much. Okay, Professor Zurabekova, if there are any questions from the attendants, I can't read. I can't read any further question in the chat. Okay. I think
here one question from our
okay.
jury.
Okay,
Dr. Youssef Shokrai.
We also welcome the Professor Shukri, the member of the jury. He will be very severe in in make this important contribution. Okay, the question is, dear students, how did you count cells in immunofluorescence technique? So I think this is a question mainly for Abdul and probably Gizem. So who wants to reply?
Miss, can we have 1 minute so I can show the open the file? Yeah.
Maria Grazia.
I'm here. I'm here.
Mm-hmm.
Ma'am, if you want, I can start to share.
Yes, please.
Here, as you can see, I already mentioned it here. Stable type, low type, high DDR, and abnormal one. Recounting the cell, recounting the picture is the same like this. And Imran will show you the picture also after that. And we make some tables like this, and we count it one by one. Approximately 100 cells, 100 foci in per picture, and we counting like this. This is the whole process.
Okay.
Miss, can I show you the pictures? So Miss, these are the pictures which Gizem said. Like we will have the pictures over here, and at the same time we will have these are the table which just now Gizem showed, and usually we calculate the low DDR type over here in this column, and the high DDR type over here, large foci with 1 or 2 foci and the 3 or more, and the last one is the abnormal or heterogeneous staining. And we will be having the total number of cases. So adding up all of this, subtracting from this number will give us the stable type of cells. So a high proportion of cells with a stable type usually indicates a normal type, but usually some of the cases showed less of the stable type and more of the abnormal or heterogeneous staining. So out of the total number of cases, very few of them usually used to be stable. But in this case, I couldn't find like any abnormal one. Usually all of them were stable, as you can see in the picture also. Usually most of them had 1 or 2 nuclear foci only. So very few, like this one had only one, only high data type, which consisted of 3 or more nuclear foci. but most of them were normal. The same applies for other cases. In this case, these green markers are usually because of the problems in the immunofluorescence, but other than that, we didn't used to count this except the ones which were present within the cell.
Okay, thank you very much.
Thank you, Ms.
Okay, Professor Zurabekova, I think we have all the information we need. I really thank you for your contribution. I know that it was difficult to make research during this pandemic, so we are perfectly aware about the situation that all of us we are living. It has been difficult for all of us to be in the lab and to make research.
This is Maria Grazia. This is question from Kumal, students. Dr.
Okay.
Kumal. Maybe she would like to ask their colleagues, students' colleagues, it was difficult or not, and how is possible to make during online this research? Maybe she would like to take the experience there.
My experience, I can share with you my experience because, okay, there is also a participant, Dr. Belli, that is my best student, now became a research grant, and I really hope a brilliant future for him. In that moment, it was difficult for all of us. If Manuel wants to speak also, of course, feel free to speak. We couldn't attend the lab. So it was a moment to write. Fortunately, we had a good amount of data because before the pandemic, we were working. So we were in a moment in which we made a lot of observation in our lab. And we used this particular period of the pandemic to collect all the data, analyze the data, and prepare manuscripts. And we published a lot actually last year. Now we just restarted our activity in the lab. I have a lot of students that asked to me if they could start, but we unfortunately we can host in the lab a very low number of students because we have to attend all the rules according to the space of the labs. So we cannot invite more than 2 students per time, together with the technicians and together with the researcher. So now we are going on. We are trying to reopen our research activities, but with low numbers. This is our experience in Italy.
Okay. Maria Grazia, here is a Dr. Aidana Pazulbek. Would like to give question for Valerie.
Please.
Aidana. Aidana, аударуға көмектесемін. I will help to translate if Aidana is his state. Aidana?
Мне интересно, сколько времени делались эти научные исследования и за сколько времени они смогли собрать данные?
Valerie is understand Russian.
Yes, of course.
Yes, Valerie, I only translate the question Aidana for all. Aidana asked, how long this results was picked up by the Valerie, and how long time he spent for this research?
Thank you. So, as the research was retrospective, it collected all the CT scans period from 2017 to 2019.
So 3 years of scanning?
Yeah. So, but it was done previously, just before, but we just took it. Like the results and made the process of description probably took 6 months because there was a lot of typical variants. It was
So 6 months to analyze all the CT scan.
Yeah.
And then
Yes.
probably another 2-3 months to organize the results.
Yes, probably.
Okay, thank you, Valerie. Okay, interesting and great work by all. Thank you, Ariane Sharma, for this comment. If there are not any more questions, I think we can conclude this session. We will give the results, I think, in the opening ceremony, right, Professor Zuravekova?
Yes. Mhm. Closing ceremony.
Closing, sorry.
No, open. Maria Grazia,
Closing
I would like give only some information about the when we organize this section. We receive a lot of application from students, research students, and some research we publish it in the abstract book number chapter 1, chapter 2, and closely to the date of this conference, some students is rejected the orally participation. I think it joined with the exam period now. Some students at the session, and maybe some students have problem with the internet or maybe tired, I don't know. So here is only here is a little group of this section, but before was a lot research projects.
So this is a very unfortunate condition, because I think it was a unique possibility, a unique occasion to show to a big audience the contribution of these students. But I understand the difficult situation that all of us we are living. So we should be very happy that the present young scientists could be present and could give us their contribution. Okay, thank you very much. So we can conclude this session and see you all to the closing ceremony.
Thank you, Miss. Bye-bye.
At
Bye-bye.
6 p.m. today.
Okay. See you in a
Thank you,
few
ma'am.
hours. Goodbye.
Goodbye.
Goodbye.